If you're a doctor practicing in the UK, you know some of the toughest calls we have to make aren't just clinical, they're legal. So today, we're building your essential field guide for the Mental Health Act. Think of it as a toolkit that helps us practice safely, legally, and most importantly, compassionately. Okay, let's just dive right into a scenario we've all either faced or know we will. You're there, in A&E, on the ward, maybe in your GP surgery. You can see your patient is in crisis. They clearly need help, but they just don't have the insight to accept it. It feels like your hands are tied, right? Well, they're not. This is exactly why the Mental Health Act exists. So here's our roadmap for today. We're going to start with the basics, the why. Then we'll get into the nitty-gritty, the main sections for hospital admission, what you can do in a real emergency, and how to handle an inpatient who suddenly wants to leave. We'll even look at what happens after discharge, and then we'll wrap it all up with a quick reference toolkit to put it all together. At its heart, the Mental Health Act is our legal framework for caring for patients when their mental disorder prevents them from making safe decisions for themselves. It's not about taking away their rights. It's about fulfilling our duty of care when a person is at their absolute most vulnerable. And to do that, we have to follow some very, very clear rules. And right off the bat, here is rule number 1, and it is a big one. The act is for treating a mental disorder. If a patient's behavior is only because of alcohol or drugs, you cannot use the act. Full stop. Making that call is a huge part of your initial assessment because getting it wrong has some serious implications. Okay, let's get into the real meat of the toolkit. When you need to admit a patient against their will for more than just a quick emergency hold, you're pretty much always going to be reaching for one of two key sections. Section 2 or Section 3. First up, Section 2. The easiest way to think about this one is as the diagnostic tool. It's for when you need to bring a patient into the hospital to properly assess them. The main goal here isn't to start some long-term treatment plan, it's to figure out what is actually going on and whether they need to be on a treatment section at all. Now, a Section 2 has a very strict time limit. It lasts for a maximum of 28 days. And here's the crucial bit you have to remember. It can't be renewed. It's designed to force a decision. By the end of those 28 days, that patient is either discharged, they agree to stay as a voluntary patient, or you've moved them onto a different section for treatment. So what if you've got a patient where the diagnosis is already pretty clear and you know that treatment is necessary for their health, their safety, or to protect other people? Well, that's what Section 3 is for. This is your go-to for longer-term involuntary treatment. This slide right here, this is your key takeaway for telling these two apart. Just burn it into your memory. Section 2 is for assessment. It's a 28-day window and you can't extend it. Section 3 is for treatment. It's much longer, up to 6 months initially, and it can be renewed. Getting this difference is absolutely fundamental. All right, let's move on. Sometimes you just don't have the luxury of time to organize a full assessment with 2 doctors and an AMHP. In an emergency, you need to act, and you need to act fast. These next sections are all about giving you and the police the power to do just that. This quote really gets to the heart of Section 4. It is purely an emergency measure. When setting up a proper Section 2 would take too long, an unacceptable delay, as the Act puts it, you can use a Section 4 to get that person to safety. It's a bridge to a full assessment. It is not a replacement for one. And it's a pretty short bridge, too. A Section 4 lets you bring a patient to the hospital and hold them for up to 72 hours. The whole point of that time is to get that full assessment done, and in most cases, convert it to a Section 2 if it's needed. Now, very often, patients will be brought to you by the police, so you've got to know their powers. A Section 135 lets them enter a private place, like a house, but they need a warrant. What you'll see far more often is a Section 136. This is when they find someone in a public place who seems unwell and needs help. It lets them bring that person to a place of safety, which is often your department, for up to 24 hours while an assessment is sorted out. Okay, let's switch gears to another really common scenario. Your patient is already in the hospital. They came in voluntarily, but now their condition has gotten worse, they've lost insight, and they're packing their bags, trying to walk off the ward against your advice. What do? This is your immediate power as a doctor. It's called a Section 5-2. It gives you the legal authority to stop a voluntary inpatient from leaving the hospital for up to 72 hours. Now, this isn't for treating them, it's a holding power. It buys your team the time you need to get a formal Mental Health Act assessment done. But what if you're not on the ward? What if you're tied up? Well, your nursing colleagues have a power too. It's called a Section 5-4. This allows a qualified nurse to hold the patient for up to 6 hours. Its only purpose is to bridge the gap until a doctor can get there to do a proper assessment and implement a 5-2.
So let's just lock this in, nice and simple. Section 5-2 is the doctor's power, and it gives you a 72-hour window. Section 5-4 is the nurse's power, a much shorter 6-hour hold just to get you to the patient. They work hand in glove to keep a patient safe until a proper assessment can happen.
Our toolkit isn't just for what happens inside the hospital. The Act also gives us a way to manage patients safely after they've been discharged, to try and break that revolving door cycle of relapse and readmission.
And we do that using something called a Community Treatment Order, or a CTO. That's under Section 17A. It lets a patient who was on a Section 3 live back in the community but with certain conditions attached, like making sure they take their meds. If they stop and their mental health starts to dip, the CTO gives the team the power to bring them back to the hospital for treatment quickly, before things get out of hand.
So, wow, we've covered a lot of ground. Let's pull all of this together into one final quick reference guide. Honestly, think of the slide as the cheat sheet you can just pull up in your mind when you're in the middle of a busy shift. Look at that. This table is basically your entire toolkit at a glance. Let's do a super quick run through. Your big admission tools, Section 2 for assessment, Section 3 for treatment, both need an approved mental health professional and 2 doctors. Then your emergency powers. Section 4, the 72-hour emergency stopgap. On the ward, you have your 72-hour doctor's hold, the 5-2, and the 6-hour nurse's hold, the 5-4. And finally, the one you'll see coming from the community, the 24-hour police hold from a public place, Section 136. That's it. That is the core of what you need to know.
And I really want to hammer this point home. This isn't just for psychiatrists. It doesn't matter if you're in A&E, general practice, surgery, medicine, any specialty. These situations will come up. Understanding this framework is an absolutely essential part of safe and compassionate medical practice for all of us. And that really leaves us with the big question that sits behind all of this. The Mental Health Act gives us the legal tools, but using them with wisdom and compassion, well, that's the art of medicine, isn't it? It's all about walking that incredibly fine line between respecting a person's autonomy and our profound duty to protect them when they can't protect themselves. It's a huge challenge, and this toolkit is here to help you face it.